And there he has kind of moved up the ranks where he is currently department chair of hospitalist medicine. At St. V's, he's the hospitalist unit director, and he's also the associate program director for the Department of Medicine over at St. Vincent's. He has also received the Outstanding Hospitalist Award there last year. So he's done really, really well, which is always really great to see. So much success. So today he's going to be speaking to us on medical myths, the non-evidence-based things we do. Thank you.
All right. Well, thank you, Dr. Stevens. And it's a pleasure to be back here. You know, I haven't actually been back to Prof Portland other than for occasional meetings in the last 6 years. I have a lot of fond memories, a lot of sleepless nights in this hospital. And some familiar faces I see in the audience who I hope to connect with afterwards, since I haven't seen a lot of these folks in a while. But thank you for that introduction. So yes, today I'm going to be talking about medical myths, some non-evidence-based things we do. I've taken a handful of these things from my own clinical practice and experience, but I have to be honest, as many things in medicine, we borrow from our peers. And I borrowed a lot of these concepts, or this talk concept actually, from an SHM, a Society for Hospital Medicine talk that I saw a couple years back. And I think it's always interesting when someone can get up and explain to you some of the things that you may have been taking for granted doesn't really have an evidence base for it. Some of them can be mind-blowing, and I hope some of these will be of fascination. I think some of them for this audience will probably be well known already, but I think it doesn't hurt to cover the evidence behind them anyway. But before I launch directly in, I hope this is a familiar face, and if nothing else, at the end of this talk, I will consider myself a success if everyone knows who this is and chooses to go watch a couple episodes of John Oliver, who does a HBO show called Last Week Tonight. But even if you don't have HBO, you can watch these on YouTube. And you're probably all thinking, how does this have anything to do with the Medical Grand Rounds talk? And if for any of those who are well-versed in John Oliver and have watched his show, you may be familiar with a segment he does called How Is This Still a Thing? And he looks at somewhat pertinent things in society, like voting on a Tuesday, daylight savings time, or Columbus Day, and sort of asks the question, how are these still things in modern society? When they really don't serve a purpose, they're not practical anymore. And so I thought this would actually be a good way to structure this kind of a grand rounds where we're looking at medical myths and ask the question, how are these still things? So what are we going to be talking about today? Well, we'll start off with one which I imagine many of you already know isn't particularly evidence-based, which is the Hohmann sign. But it's early in the morning, and I figured this will at least get the juices flowing and get you guys prepared to hear the rest of these, some of which will probably raise some more controversy. But we'll start with a simple and easy one. We'll move on to radio contrast reactions and shellfish allergies, touch a little bit upon iodine allergies, which hopefully I can convince you, if you don't already believe, is not a thing. And then we'll move on to what I think will probably be the more interesting, it was when I gave this talk at St. Vincent, and the more controversial, which is the use of cephalosporins in those patients who are penicillin allergic, and the fact there's actually pretty good evidence that they are, for the most part, safe with some exceptions. And we probably underutilize cephalosporins in patients who are penicillin allergic. And then finally, I'll follow up with a piece on routine replacement of peripheral IVs and the evidence that actually suggests that you don't need to routinely replace peripheral IVs. I think something as physicians we don't think too much about, but nonetheless is kind of an interesting topic. So we'll follow this kind of a structure. So we'll talk about the myth, which is a widely held but false belief or idea. There's a lot of this in our political system these days, but we won't get into that. Reality, the state of things, that they actually exist. We'll talk a little bit about the impact of these myths, as well as the origins, some reasons for why these myths exist and how they continue to be, how they continue to persist. I have no financial conflicts of interests, just to get that out of the way. Okay. So we'll start off with Hohmann sign, and feel free to ask questions during the talk. You don't need to wait till the end, since we are talking about 4 different topics. It'd be reasonable if at the end of each of them, if you have any particular questions, please don't hesitate to ask. So the myth here is that the Hohmann sign helps to evaluate for DVT. So as a physical exam finding, this can be helpful in trying to assess your patient for the presence or absence of DVT. The reality is that the Hohmann sign actually provides no useful clinical information, and for the most part should be struck from any medical education that we do.
Have you described Hohmann sign?
What's that?
Describe the Hohmann sign.
Yes, I'm getting there. So, and I will get there in just a minute. We'll talk about what the Hohmann sign is. But the impact of this is it perpetuates an invalid exam finding. It could give you false reassurance. So if you have a negative physical exam finding, you may think the patient doesn't have a DVT. Lost time in performing the exam. And it could cause patient stress or anxiety if a patient believes they have a positive exam finding. So what is the Hohmann sign? So it was described by a surgeon back in the 1940s, John Hohmanns. And the test goes something like this. So you raise up the patient's leg, you put your hand behind their popliteal fossa, you passively dorsiflex the foot, and because the theory goes there's a fibrinous clot sitting somewhere in a deep vein, and there's probably some surrounding inflammation within that vein, when you dorsiflect, it causes pain, specifically in the popliteal fossa, and that was considered a positive Hohmann sign. And it was described by John Hohmanns, and this sign was attributed to him, although even he later on said, I wish someone would have attributed a better sign to me. But this one's been fairly well debunked as a useful physical exam finding. So the Rational Clinical Exam has looked at this. And the sensitivity is awful, worse than a coin flip. So even a negative test may actually be more likely to predict a DVT. So clearly not something we should be using. Specificity also quite poor. And I read one article where this physician assistant very, I think, appropriately said, so Hohmann sign is a test that should be allowed to rest peacefully in the archives of medicine, which I fully agree with. If you are looking for a good physical exam finding for DVT, there just isn't one, but the best that's out there, which still doesn't help you in your clinical decision making, in my opinion, but is the asymmetric calf swelling of a greater than 2 centimeter difference. That gives you a likelihood ratio of about 2. And if you were to plot that out on your Fagan's nomogram, you would actually see that that would increase you from your pre-test to post-test probability by 15%. Certainly for DVT, especially not enough to influence any kind of clinical decision making. So there really is not a good physical exam finding for DVT. Stick with lower extremity Dopplers if you want to answer that clinical question. Anyway, that might be more, if there's any residents here, they probably know what that's like. All right, so moving on to the next topic, and I think this is a bit more interesting, I think, than the Hohmann sign. Shellfish allergy and radio contrast. And I will show you that this actually, and many of you may already know that there's really no connection here. It's been fairly well documented, but I'll show you some data that shows among physicians it's actually still not that well understood. But the myth here is that an allergy to iodine and or shellfish increases the risk for IV contrast reaction. There's already a problem with this statement in that allergy to iodine, that's really not, there's no such thing as an allergy to iodine, which I'll explain, but nonetheless, this is the myth that exists. The reality is that there is actually no value in screening patients for an iodine reactions or shellfish allergy prior to iodinated contrast media administration. So the impact here, confusion, anxiety for patients being told they have an allergy or can't receive a test that they're being recommended for. Potential delay in appropriate testing or intervention because we don't want to use contrast with that particular study, or we do a suboptimal study that doesn't use the contrast and doesn't give us as good pictures. So cost and unnecessary treatment. So I'll show you in a minute that there are actually studies where physicians will fairly routinely pre-treat patients who have a listed iodine allergy or shellfish allergy with things like steroids and antihistamines prior to giving them iodinated contrast, a practice for which there's no evidence for. So those are some of the potential impacts. So where did this myth come from? As best as I could tell, looking back through most of the literature, in 1975, this particular investigator published a retrospective review of patients who had iodinated contrast allergy, or reactions, shouldn't call it an allergy, had iodinated contrast reactions, and this is back when we used to use high osmolar contrast media, which was more common, or more commonly caused reactions. And she noted in the survey of these patients that 15% of them listed an allergy to shellfish. So in her conclusions, she made the connection that, you know, a shellfish allergy, there's an increased correlation between shellfish allergy and the reaction to iodinated contrast. And she surmised that the reason for this may have something to do with iodine, because there's iodine contained in both these things, and maybe it had something to do with the iodine, or with the substance iodine. This actually should have probably been shot down to begin with, in part because what people react to in shellfish are known antigens. Tropomyosin and parvalbumin are the most common. This is what people actually develop an IgE type 1 hypersensitivity reaction, a true allergy. It's a known, affects about 6.6 million people a year. But iodine is simply not an antigen. It's been tested in vitro. You can't make antibodies towards that. And if you did, it would not be compatible with life. You need iodine to survive. The interesting thing is we still don't know exactly what about iodinated contrast actually causes the allergy-like reaction. We don't know what causes the anaphylaxis-like reaction. There's some theories that are floating around, but it's not an allergy. You don't make IgE antibodies to that contrast media. So just to run through one more time for you folks, this was a review for me as well when I built this slide, because I don't think about sort of the anaphylactic cascade that occurs. But just to run through what actually happens and to show why iodine and contrast really doesn't fit this picture. So when you ingest a true allergen, something like seafood, or you're exposed to it, that antigen gets eaten by antigen-presenting cells and presented to B cells, which then convert over to plasma cells. Those plasma cells are responsible for producing antibody, in this case IgE. And then the next time you're exposed to that antigen, that IgE binds to the antigen, activates those mast cells, and then you get the mast cell degranulation, lots of histamine, and the allergic reaction, whether that's anaphylaxis, hives, what have you. Now the theory is, they've actually tested, and I didn't list these studies, but they actually have looked at iodinated contrast in vitro to try to generate antibodies to this, and have been largely unsuccessful in the lab. What they suspect, though, is what happens here is that iodinated contrast material destabilizes mast cells through another mechanism. They're not really sure why, but it's not an immune-mediated mechanism. And then that's what leads to what effectively clinically looks exactly the same as an anaphylactic reaction, but is actually not a true anaphylactic reaction, and so they call it an anaphylactoid reaction. And in this case, remember, iodine simply cannot act as an antigen, so it cannot trigger this pathway. So the idea of having an iodine allergy is just simply not possible. I did bring up one other thing, because I think this may be another explanation for why people conflate this idea of iodine allergies, because there is a true thing. Povidone iodine or betadine can cause an allergic skin reaction, which is a type 4 delayed type hypersensitivity. But this is caused by the povidone, not the iodine. So another thing to help, especially if patients have a misconception that they have an allergy to iodine, it's actually to the povidone component, not to the iodine itself. But that may be another reason why this persists. So, some survey data. This was actually an interesting survey done in 2005 that took 75 patients and surveyed their understanding about seafood and iodine, and whether there's any relationship between those two substances and a reaction to iodinated contrast. So just trying to get a sense of what's out there to the lay people and to our patients. Of those 75 patients, 65% said they had read or been told to avoid iodinated contrast as a result of the fact that they had a seafood or iodine allergy. And a full 92% believe that iodine was responsible. So gleaning from this study, our patients oftentimes have misconceptions, which is not necessarily a big shocker to most of us. But I think we can look to physicians as to why this may actually be, and physicians are probably propagating this. So a more recent study in 2008 looked at 113 physicians, and they actually looked specifically at radiologists and cardiologists, two particular specialties that are more commonly using contrast, whether it be for an angiogram or for contrasted CT. And they asked a couple questions of those providers. They asked if those providers inquire about a history of seafood or shellfish allergy prior to administering contrast to their patients. 65% of radiologists said they asked this question, and almost 90% of cardiologists said they asked this question. What was actually more interesting is, do they do anything with that information? So they asked, based upon that, do you withhold contrast media administration or recommend some sort of pre-medication prior to administering their contrast if your patients have a seafood or shellfish allergy? And a full third of those radiologists said yes, they do, and 50% of cardiologists said they do, which is also interesting for a couple of reasons, this result. One, it shows that people are actually propagating this myth and they're doing things to their patients based upon it. But also, they're asking questions. Almost half these cardiologists ask a question that they ultimately don't do anything about, which is kind of an interesting thing. So it begs the question, why ask if you're not going to use that information? So I'd argue that we as physicians are actually propagating this myth to a large degree. And it's not just in this country. It's also in the UK. So this was a study that came out even more recently in 2014. Looked at 100 providers that they send out a survey to, which represented about 20% of the United Kingdom's cardiologists. And a full 66% of those providers routinely ask their patients about iodine or shellfish allergy prior to contrast administration. And half of those would actually pre-treat with antihistamines or steroids. So this, again, supporting this idea that we as physicians are probably propagating this myth. Fortunately, there have been a number of studies that have tried to answer this question of whether there's anything truly, if there's anything there, if there's any connection. And probably, and I'll explain this table in a minute because it's a bit busy, but probably what really this all comes down to is that if you're a patient with allergies, there's just an increased risk that you're going to have a reaction to contrast media, but there is no immune basis for that. It's just people who tend to have more allergies tend to probably have more, I guess I would say, trigger-happy mast cells. They're just more likely to be stimulated. And that's what this data really bears out. So this study here, so this was a systematic review done in 2010. This study here, you'll remember, is the first one that I quoted back in the beginning of this section. And here's that data that showed a 15% of all the patients who had seafood allergies that reacted to high osmolar contrast media, 15% of them had a seafood allergy. But if you'll see other food allergies, here's 13% for all food allergies. Prior contrast's reaction was about 17%. If you keep going, so general allergy, about 12%, which is above the baseline of all comers of about 5%. And then as the studies keep going, it sort of shows a similar thing, that a general allergy does seem to increase your risk of contrast-associated reactions. But what's interesting here, so that's one part. So it seems to be more correlated to just simply the fact that you are an allergic individual, but not anything to do with what specifically you're allergic to. And then the other take-home point from this is that even with a prior contrast reaction, your incidence of having a reaction the second time is still not overwhelmingly high. And this goes back to reinforce the point that contrast reactions are not true allergies, because generally speaking, if you have preformed antibody against an antigen, you're going to have that anaphylactoid reaction generally the next time you get exposed to that antigen. And in this case, it's actually not that common that you have another reaction after contrast administration. So this has actually led the American College of Radiology, and they've updated this statement for years now, but this has been there for a number of years, came out with this statement that the predictive value of specific allergies, such as those to shellfish or dairy products, previously thought to be helpful, is now recognized to be unreliable. A significant number of healthcare providers continue to inquire specifically into a patient's history of allergy to seafood, especially to shellfish. There's no evidence to support the continuation of this practice. So they've come out against asking any of these questions, and I think that data bores out the reasons for that. So in summary, really no benefit in screening your patients for seafood or iodine reactions prior to giving contrast. Patient with any true allergy, so food, seasonal, drug, are at increased risk for reactions to iodinated contrast. Not that we pre-treat these folks, but it's just something to realize. And severe contrast reactions are anaphylactoid. They're actually not a true allergic reaction. They're a pseudo-allergy. And just as a reminder, iodine is not an allergy. When you actually Google iodine allergy, you'll see a number of non-medical providers who continue to talk about what your doctor will do if you have a listed iodine allergy and what foods they'll tell you to avoid. It's actually kind of interesting. Yeah, question?
Just a comment. I am one of the guilty cardiologists that asked the question. If I get the answer, you wouldn't say that I don't do anything. I inject them with 2 cc of contrast material, carefully watch what happened to their blood pressure and heart rate. Usually nothing happens, and I follow with the study.
Yeah.
So you cannot say you don't do nothing.
Sure,
You are
okay.
more likely to get allergy reaction, as you said.
Sure. Sure. And being more cautious or aware that something may happen. Yeah, true. True.
Can you repeat the question, please?
So it was a statement saying that that as a guilty cardiologist that does actually ask their patients about this, they don't do anything in response to the patient's answer that they have an allergy, but that they watch they give a small load of contrast to begin with, watch their patient for a reaction to see what happens before kind of continuing on with the study. So they do use the information, even though, as I alluded to, the cardiologist in that study didn't necessarily act upon that information. In this case, they are potentially acting upon that information by watching their patients more carefully when they have a listed allergy. Okay, so I think this will probably be the more controversial of the topics and maybe the most useful to people's daily clinical practice, actually. But it's to talk a little bit about penicillin and cephalosporin cross-reactivity. I actually fell into this topic after a case review I did as the department chair when there was a patient who was upset that he had been given a cephalosporin despite having a listed allergy to penicillin in the chart, and blamed a number of disparate symptoms on the fact that he was given a cephalosporin, although he had no objective negative outcome as a result of getting cephalosporin. But it caused me to delve fairly deep into this topic to try to see, is there any basis for being concerned when giving patients cephalosporins who have a listed penicillin allergy? So the myth here, and this is what I remember keeping in my mind for a number of years, is that there's a high, roughly 10% cross-reactivity rate between penicillin and cephalosporins. This is what I carried with me for a number of years, actually, until I did this review. But the reality is the cross-reactivity rate is relatively small, probably at best around 1% or at most around 1%. Between penicillin and all comers, all cephalosporins. I'll talk a little bit about how it varies based upon the generation of cephalosporin. But I think one of the key take-homes is that there's really no cross-reactivity with 3rd or 4th generation cephalosporin. There's no evidence that these are unsafe in our folks with penicillin, and hopefully I'll convince you of that with some of the data. So the impact of this, I think we could all run through in our own minds with the impact of when we have a patient who has a penicillin allergy and it limits the number of antibiotic options we feel we have, but it reduces those treatment options. It could potentially increase treatment failure because you may choose a less effective antibiotic as a result of them having a penicillin allergy. You may expose them to unnecessary toxicity by using an antibiotic which has a higher side effect profile than cephalosporins, many of which have a fairly low side effect profile. Increased costs simply by using a more expensive antibiotic. It may violate some of our antibiotic stewardship and lead to bacterial resistance. There's been a push, many of you probably already heard, in our effort to battle things like C. diff colitis. They're pushing us away from using fluoroquinolones, and fluoroquinolones are a very common antibiotic that we jump to when people are penallergic, because those are usually well tolerated in our penallergic population. So those are some of the potential impacts of this myth. Now, the origins in this kind of get back down to sort of a biologic plausibility, I think, at the root, and that is there are chemically structurally similar, or rather, structural similarities between our cephalosporins and our penicillins. And I think what often gets misidentified as the cause for cross-reactivity is actually the beta-lactam ring. I didn't go into all the in vitro studies that were done. There were a handful of them that tried to actually generate antibodies to a beta-lactam ring and try to see if that was potentially the area of antigenicity that was leading to the cross-reactivity. I didn't see anything convincing that that was borne out, but I think that's where a lot of the focus is when people think that there's cross-reactivity. It has something to do with the beta-lactam ring. We'll talk about some of the literature here. I will point your attention more to the IR1 side chain, which probably has the more antigenic effect and is probably what, if there is cross-reactivity, is what's leading to the cross-reactivity is when you have a similar R1 side chain in these molecules. So that's one place where I think this myth comes from. And then the other is simply the early publications that came out in the 60s, which found a 10% cross-reactivity when they looked retrospectively at patients and exposed patients to cephalosporins who had a known penicillin allergy. The difficulty is that all of these studies are marred by the fact, they looked at these particular cephalosporins, which we don't use anymore really, but they were marred by the fact that the manufacturing process that was used to create these cephalosporins were done in a fungus called acremonium, used to be called cephalosporium, and it was known to be contaminated in many of these drug companies, contaminated with a low level of penicillin. And so the cephalosporins likely had a small amount of penicillin in them. And so it's hard to know, were they reacting to some component of the cephalosporin or were they actually reacting to the penicillin themselves? So a lot of the early data that was used to drive this 10% cross-reactivity, it's hard to draw good conclusions from. So I think that's where this myth initially started. But before we jump into convincing you that there isn't as serious a cross-reactivity issue, I did want to kind of give you a sense of where the state of things are with respect to physician practice behaviors. At some point, I would like to have put an audience response in here to have polled my audience, but this will do as a surrogate here. So this was a study that was published in 2002 that surveyed several different groups of providers, I believe internists, pediatricians, allergists, and I believe students, medical students. And they presented them with cases just to see what their practice habit would be. And they varied those cases subtly to see how it would influence the physician's choice of antibiotics. So the case they started with was an otherwise healthy patient, came in with sinusitis, bronchitis, looks otherwise clinically stable, has a history of a macular papular rash from penicillin in the last 10 years. You consider a cephalosporin, but what would your ultimate decision be in treating that patient? And so they gave several options, including a penicillin, a cephalosporin. You could choose a non-beta-lactam antibiotic like macrolide, like a macrolide, Bactrim, or doxycycline. You could refer them to an allergist, or you could give them their first dose in the office, wait 20 minutes, hope nothing happens, and send them home. And then they varied the scenario a little bit. They said, okay, take the same patient, but let's up the ante a little bit and say that they had potentially a more anaphylactic type reaction to penicillin. How would that influence your decision? And then finally, they changed the type of hypersensitivity reaction and said, okay, let's say they have a penicillin-induced hemolytic anemia, which is not an IgE-mediated response. What would you choose then? And I'll walk through this with you because I think it's actually somewhat interesting. So not surprisingly, and I think as in my clinical experience has been when you tell somebody, tell a practitioner that their patient has a penicillin allergy, they obviously avoid penicillin. Most of them, I think, and internists are here on the left, avoided cephalosporins. The pediatricians actually were the ones that went more out on a limb and chose the cephalosporin. But even allergists, largely avoided the cephalosporin. And this is, again, for a penicillin-induced rash, which is not necessarily, it's not an IgE-mediated, not an anaphylactic reaction. Of course, when you did raise the specter of anaphylaxis, universally across the board, no one's going to choose the penicillin. Basically, nobody's going to choose the cephalosporin. A few people recommend some skin tests. And then a penicillin-induced hemolytic anemia looks pretty similar, so no one's choosing the cephalosporin. And I would argue that for the most part, cephalosporins in any of these scenarios, especially the third-generation cephalosporins, are actually safe to use, and these physicians are missing an opportunity to use potentially a more effective antibiotic and not worry so much. And we'll get into that data in just a second. But there was a fourth case in here, which I thought was at least humorous to mention. So they upped the severity of the patient's illness. So in this case, they say it's a hospitalized patient that's septic. They have bacteremia, growing a bacteria that's only sensitive to penicillin and cephalosporins. I'm not sure what that would be. Nonetheless, it's a hypothetical. The patient has a history of a penicillin allergy, but we don't know what that allergy is, which I think is the most common bucket that we all tend to fall in, is someone says, something happened, my mom told me that I had a reaction or a rash or something 30 years ago to a penicillin. But then they ask, what would you do? And I apologize for the less good quality of this particular slide, but I blew this one up because I thought it was fairly interesting. So internist, I think this is the universal sign for I don't know. It's a third, a third, and a third. No one prescribes the penicillin. Okay, I get that. But I don't think anyone knows. The pediatricians, I do like how we do reach out for an ID consult. When in doubt, ask ID. But the pediatricians, kind of similar, although a little more willingness to prescribe a cephalosporin. My favorite here is actually, though, the allergists. And I apologize if there's any allergists in the audience. But in a septic patient who's bacteremic, you probably don't want to wait for the results of your skin test to come back to start an antibiotic. You should probably start something and then consider a skin test down the road. But you can clearly see where their bias is. And I think students were kind of mixed. And I think this is oftentimes where we often fall, is in this category. We're not really sure with the penicillin allergy what to do. Hopefully I'll clear that up a little bit. Okay. So let's start with the evidence for why cephalosporins are likely to be safe in our patients who have a penicillin allergy. So there's some retrospective studies that have been done over the last decade and a half. So back in 2001, there was a study that was done in surgical patients, published in the anesthesia literature, that took 2,900 patients who were going for elective surgical procedures, who were going to be given prophylactic cefazolin prior to surgery. 300 of those patients had a listed penicillin allergy, but were given the cefazolin anyway, and there was only one adverse event among that group. The next study, done in 2004, looked at 27,000 patients retrospectively who received cephalosporins as inpatients. Doesn't obviously clarify which cephalosporins. 606 of those patients had a listed allergy to penicillin. There was, again, only one adverse event, so a 0.17 cross-reactivity rate in that population. And then probably the biggest study that was done, and I think the methodologically better study, looked at about 500,000 patients. This study was done out of the, I believe out of the UK, or out of Great Britain. They did a chart review of patients retrospectively. They looked at patients that were given penicillin, followed them for looked in the chart 60 days ahead to see if any patients were given a cephalosporin or a sulfonamide antibiotic, and then they broke them into subgroups. So of those 500,000 patients, there were 3,920 patients who had an allergy to their index penicillin event, and then subsequently given a cephalosporin. And of those patients, there were only 43 adverse events, about 1.1% of them. And what was, I think, more interesting and made this more powerful results is they also looked at people who had a reaction to that index penicillin, but then were subsequently given a sulfonamide antibiotic. And interestingly, they had 10 adverse events at 1.6 for a lower but similar risk ratio. It's kind of suggesting that maybe it doesn't necessarily have anything to do with penicillin, cross-reactivity with cephalosporin, but maybe, again, this notion, which we talked a little bit about with the radio contrast, that allergic individuals just tend to be more allergic to things. But again, leading us to a conclusion, if you kind of sum all these together, of a cross-reactivity rate that hovers around 1%, not the 10% that was initially thought. But we don't leave it there. So there was a meta-analysis that was done in 2007 that pooled together data from a handful of studies, because there's simply not a ton of studies, but these included the early studies that were done in the 60s and 70s using the first generation cephalosporins, which had potential contamination with penicillin. But they also looked at other classes of cephalosporins, second generation and third generation cephalosporins, and pooled what data there is. These are not huge numbers of patients, but again, this is an area where we're not going to likely get a large epidemiologic study to conclusively tell us. But they nicely put these into forest plots for us, which I think illustrates the point pretty well. So everything, just to orient you, because this text is pretty small, everything to the right here suggests greater cross-reactivity in the penallergic. Everything to the left here suggests there isn't any reaction in the penallergic. And obviously anything in the middle suggests there's no statistical significance. I put this box here just to remind you. So these are all the first-generation cephalosporins. So this particular area here is looking at all first-generation cephalosporins. All these studies were done early. These were all done when potentially with cephalosporins that were contaminated by penicillin. And yes, they all show statistical significance or they all reach statistical significance that there is a cross-reactivity between first-generation cephalosporins and penicillins. But what becomes interesting, and moving on to the second and third generation cephalosporins, the ones I highlighted there are the second generation cephalosporins, and the ones in between are the third generation cephalosporins. Of the studies that have been done, of the data that we do have not shown that there's any connection between them. So again, anything that crosses 1 here is not going to reach statistical significance, so there's really no cross-reactivity in that group. So that study was done in 2007, and then there was a literature review that was published in the Journal of Emergency Medicine more recently in the last 5 years, which looked at many of the different articles. They didn't pool data, they just looked at what existing data was there. And they came up with this conclusion that overall cross-reactivity for reported penicillin allergies is about 0.5 to 1. Confirmed penicillin allergy, which is important, is 2.55%. So again, lower than that 10% cross-reactivity. But they also came to the conclusion in their study that it's safe to administer a cephalosporin with a side chain that is structurally dissimilar, or a third or fourth generation cephalosporin in patients who are penicillin allergic. And what they postulated was that this really has to do with an R1 side chain specific effect. These antibiotics here, many of which were the ones that were studied in that meta-analysis and showed cross-reactivity, share an R1 side chain with penicillins, amoxicillin and ampicillin, which is probably why there's greater cross-reactivity in those. But the third generation, fourth generation cephalosporins do not share this R1 side chain and therefore don't have any significant cross-reactivity. So in summary, yeah?
On your study that looked at the 500,000 people,
Yeah.
was there a reaction to cephalosporins in people that didn't report penicillin allergy? What was the
Yes.
baseline comparison?
Yeah, so the question was there a group of people who had a reported reaction to let me see if I get this right, to cephalosporins but not to penicillin? Is that? There was, I don't remember what the number was, but they did actually, I believe they put that in the study. They actually listed, and I can't remember what that number was. But that's a good question. That's a good point. Okay, zoom ahead here. So in summary, take a good history. And one thing I didn't talk about, but if you're interested, I have a slide about it at the end I can show you. But, and this has been in the literature here and there as actually only about less than 10% of people who list an allergy to penicillin actually have an allergy to penicillin, which is probably why our cross-reactivity rate in part looks low in some of these retrospective studies, is because they don't truly have a penicillin allergy to begin with. So it's a bit of a difficult thing, but take a good allergy history, know what their allergy actually is, what their reaction is, make sure it's actually a type 1 hypersensitivity IgE-mediated reaction. In patients who have adverse reactions to penicillin that are vague or uncertain if an allergy, I think the data suggests that it's safe to prescribe a cephalosporin with a dissimilar R1 side chain, but certainly any third generation or fourth generation cephalosporin is safe. There really is no evidence that you're putting your patient at increased risk. That isn't to say they can't have an allergic reaction to a cephalosporin that is independent of a reaction to penicillin, and I would totally understand you taking your patient's perceptions into account. They may say, hey doc, I had an allergy to penicillin, why did you give me this? I had a reaction to cephalosporin too. But the reality is the data doesn't support that there's any connection between those two things, and that they're kind of true but unrelated. So in a patient, so it becomes more difficult. What do you do in those patients who have a true type 1 IgE-mediated reaction? So I would still say there's really no evidence that there's increased risk for third generation, fourth generation cephalosporins. I think it's going to make us all uncomfortable to go ahead and give that to somebody who we know had an anaphylactic reaction to penicillin, but there is no evidence that they're at any increased risk over anyone else with any other kinds of allergies to third or fourth generation cephalosporins. So we're probably just not using a potentially effective antibiotic. But I would avoid, at least at this point from the data that exists, first generation and any second generation that has a similar R1 side chain to penicillin. The data does seem to suggest that there is increased risk there, so I would avoid those. I got two questions. Cortland, in the back.
With like antibiotic stewardship, we're using a lot of first generation cephalosporins right now.
Right.
So do you have a go-to first generation that does have a dissimilar R1 side chain? Flex was in the bad version.
Yeah, so at least as an IV, I still tend to use Ancef or cefazolin, especially patients with a vague history. I'll use that. As far as another oral, no, I tend to just shy away from the first generation cephalosporins as a general rule. The studies haven't been done to make us feel more comfortable that the first generations are acceptable. Because yeah, Keflex is one of the ones that unfortunately fall in that category with a similar R1 side chain.
What's the incidence of allergic reaction to cephalosporin in patients who give no history of allergy?
That's a good question. So the overall incidence, of anaphylaxis, I think it's quite low. I think it's in the order of somewhere between 1 in 1,000 to 1 in 10,000 type reactions in patients who just don't have any history who come in de novo. So it's fairly uncommon to have a cephalosporin allergy to begin with. Yeah.
Thank you very much.
Sure.
Great talk. Have people studied the appropriate use of skin testing and other ways to kind of figure out what's going on with this, 90% of people who say they have a penicillin allergy actually don't?
So, so the question was what's the use of things like skin testing or other immunologic testing to try to determine people's underlying risk of an allergy or reaction to these drugs. So through most of these studies that I reviewed, it was hit and miss as to whether skin testing, which I think is inherently difficult to interpret as far as what clinically is actually going to happen with these patients. So what I was putting together, and if there's any allergists in the audience, feel free to speak up and correct me because this is not my area of expertise, but that skin testing is flawed in general and doesn't necessarily give you reliable data as to what the person's actual clinical reaction will be. The RAST testing I've heard is a little bit better in determining what people's actual reaction will likely be. Certainly in the population of patients who were formally tested and confirmed with either skin testing or RAST testing seem to weed out a good portion of people who don't have any reaction. So I think if those things are negative, I think you can more reliably feel that they don't have an allergy. But if it's positive, I'm not sure how much that moves the needle. Yeah, Jim?
Antibiotic stewardship papers that show it's very safe to just give a test dose of penicillin G or to give a dose of amoxicillin and just go ahead. And then there are some papers, stewardship and focus to the skin testing and show the same thing. But we can't get skin testing here.
Yeah. Yeah.
I just wanted to throw in an interesting thing. In the Falklands War, the Navy and the Army that went over there from the UK gave everybody that needed it O negative blood.
Okay.
There were no reactions. And he was on cross-match. No time. On board ship or whatever. They also gave anybody that needed antibiotics, whether they said they were allergic or not to penicillin, penicillin. There wasn't a single reaction. That was in the early 80s, that's 37 years ago, somebody noticed that. It wasn't a study, it was a necessity, but...
Right. And I think we, just as the kind of adverse culture that the safety first culture that we live in, I think we try to avoid any potential for problems or any potential for reaction. And I think in this particular area, especially in my clinical practice, I see it far too often. The ED providers and my own colleagues and myself leading up until I kind of looked into this more would just knee-jerk reaction. I don't want to take the risk, but the risk really actually isn't that substantive. So, okay. All right. So the last topic is the routine replacement of peripheral IVs. And full disclosure, this was a topic that I saw at SHM, and I just thought it was interesting because I think as physicians, we don't tend to think very much about IV replacement and what we should do. We think a lot about central lines. There's a lot of focus on central lines and what you should do for central line due to their risk for bloodstream infections and remove those as soon as possible. But what about peripheral IVs and replacement? What do we do with those? And for a long time, there were guidelines that suggested that we should be replacing peripheral IVs every couple of days because the longer you leave those in, the more likely you're going to see complications. So the myth here is that peripheral IVs should be changed routinely to prevent complications, phlebitis and infection primarily. And the reality is there's actually no benefit in the routine changing of peripheral IVs, and that changing them when clinically indicated actually reduce cost without putting any additional risk onto our patients. And so I'll show you the data behind that. The impact of the myth of chasing these routinely, well, decreases patient satisfaction. Certainly being poked by more needles don't make our patients any happier. Increases financial costs. So each time you place an IV, especially in a hospital like this, there's IV therapy costs, there's the hardware costs, and increased healthcare worker time in the process of having to place these. So Origins actually went more to a brief history of IVs because I thought this was interesting. I stumbled upon this in one of the studies that I read, put this in their initial discussion. So the first IV set, I don't know how true, if this is just apocryphal, but was a quill, a pig bladder, and animal veins, and the first infusion is wine, ale, and opium. Although I swear I've had some patients who have tried that infusion more recently with poor effect. First hollow needle in 1845, first metal syringe in 1853. First catheter over needle design, which we all know and love now, was actually invented in the 1950s. And then interestingly, only in the 1970s were nurses allowed to place peripheral IVs, which is amazing for a younger physician like myself who didn't realize that nurses didn't always place IVs. But these are the two things that we're most worried about, phlebitis and bloodstream infections. And I think it's, just from a plausibility standpoint, probably why the idea of changing out and putting a newer, fresher one and changing the site might reduce the risk of these complications. I think there's a certain makes sense argument for that. But the literature doesn't really support that, and I'll show you that in a second. But some fun facts about IVs. It is the most common invasive medical procedure. 80% of hospital admissions average about 2 vascular devices. 200 million of them are placed every year. Keep in mind that's not just hospitals, but does include places like long-term care facilities, nursing homes, etc. So the current guidelines, and I thought this was interesting. So Providence nicely has already gotten on the bandwagon. They changed their peripheral IVs only when clinically indicated. And then the NICE, which is the UK standards, also say that as well. But for some reason, our CDC, and this is last updated in 2011, has been slow to adopt this in adult patients, interestingly. So they make no recommendation regarding the replacement of peripheral catheters in adults only when clinically indicated. They consider it an unresolved issue, which I think it's resolved. I'll show you a Cochrane study and a large meta-analysis which resolves this issue. But interestingly, they don't have a problem of leaving them in children, which I kind of thought, I wonder how they justified that as they were writing number 2 and then hit enter and started writing number 3. How did that work? Because are we then just putting our children at increased risk? That doesn't seem right. I would argue that part of that is because children are much harder to stick with needles, and you don't want to stick your children with needles, and so that may be why that recommendation allowed for children. But where's the data for this? So there was a large multi-center randomized controlled trial, which I think put this to bed, and then a subsequent Cochrane review that looked at this. But they essentially took about 3,400 patients, randomized them after excluding a few who already had pre-existing bloodstream infections and such. They randomized them to 2 different groups, one which was going to get a peripheral IV that would be removed only when clinically indicated. And I'll get into what that means. And the other one assigned to a group where you replace them routinely every 3 days, and then they just followed them going forward to see what happened to those patients. And so here's the breakdown. Small numbers, but I will give you the gist of it so you don't have to worry too much about what all these numbers show. Their primary outcome in an intention to treat, and they also did per protocol analysis, was phlebitis. That was their primary outcome. And there was no difference between the 2 groups. So the p-values over here of 0.64, 0.67, 0.39, 0.32. There was no difference in the outcome of phlebitis. And then they looked at all these other secondary outcomes, any infusion failure, so the IV stopping, not functioning for any reason, infiltration, occlusion of that IV, catheter-related bloodstream infections, all bloodstream infections, local infections, and interestingly, mortality they actually threw on there. So they threw a lot of different secondary outcomes, none of which reached statistical significance. So there was no difference in the study between the group that got an IV changed every 3 days versus the group who you just left it in until the IV failed on its own. Or they saw evidence of phlebitis, obviously, if you see something wrong with it. The interesting thing was, where there was a big difference was costs. So this was done in Australia, but it saved about $7.58 per patient. But what's interesting, okay, I didn't get there yet. But when you multiply that between the number of IVs that are saved, that actually turns out to be a big number, and I'll show you that in a second. But it saved a significant amount of cost without any additional risk. Cochrane looked at this as well. I won't belabor the point too much, but they looked at 7 studies that were qualitative, 5 studies in meta-analysis. They plotted it out on a forest plot. Again, to the right favors a 3-day replacement of IV. To the left favors replacing IVs when clinically indicated. And you can't really tell, but that actually does cross 1, that diamond there. And so no statistical significance there. And this is for phlebitis, an outcome of phlebitis. This is for an outcome of bloodstream infections. Again, they pulled that data, crosses 1, no statistical significance there. But cost had a statistically significant and favored changing the catheter when clinically indicated, not at 3 days. So in summary, you want to replace your peripheral IV sites only when clinically indicated. It can save the healthcare system about $300 million over a 5-year period if you do that, about 1 million healthcare worker hours per year. Number needed to treat is pretty low. Only need to apply this rule to 5 patients to prevent 1 extra IV replacement. Your patients will appreciate that, and it caused no additional harm. Okay. Thank you. Other questions, I guess, we can open up to. All right. If anyone has any other questions, feel free to come down to the front.
Thank you.
Yeah.
It was a very nice presentation.
Oh, sure. Thank you very much.
Very practical.
Yeah.
A lot of people talk too much. President, little bit.